Hey guys, it's Nina Hart, and I am here with Alicia Montelongo Vargas, and we are super excited to be here today. And we were talking about how we could most effectively help hospices and most effectively address some issues that we're seeing. We're celebrating 2,000 ADRs completed. It's very exciting. And we're looking at trends. We're looking at the things that we're seeing in those records. And we are here today just to talk to you about one of those things, which is determining and proving that prognosis. So I'm really excited. I don't know about you, Alicia, but I'm excited to talk about this.
Yes, I'm super excited. One of the things about ADRs is it's very straightforward, and if we figure out the formula, it's like a math problem. If we figure out the formula, it's just the same thing over and over again. So I'm excited to be able to show everyone what that looks like so that they can be successful in their ADRs.
It's really important for me for things to be super practical and like applicable. If I can't like take the information and apply it immediately, it's not really helpful for me. So what are you, I guess, starting with like the obvious, like why is it getting harder, or what are you seeing in, you've done a lot more audits than me. So what are you seeing in these records, or why is it getting harder for them to prove prognosis? It seems like this would be one of the most, to me, it seems like this would be the simplest thing. We have our Medicare regulations, and no shade to CMS, but I'm going there. They have this thing where it says that our medical director, our physician, is writing the CTI, the certification of terminal illness, and they're attesting to that prognosis. So why isn't that good enough anymore? Like that seems like it would be really straightforward.
Yes, I do believe that it is straightforward, and I think that we have several things happening, right? One, we have the reviewer. The reviewer, in some occasions, are asked to go through a list, right? And so if they don't see specific verbiage or they don't see specific decline in that documentation, then that becomes an issue. Another thing is that we do have some physicians that use too much nursing terminology, and so a nurse and a medical director speak different and look at a disease process different. And so we want to make sure that the physician is using the terminology that is applicable for that decline in that patient. And using the term decline is very important. And so I think
just be the words they choose to use to
a lot of
reflect.
it yes. It can be verbiage, and when you have two consecutive episodes or two consecutive certification periods or benefit periods, I get the home health and the hospice sometimes intertwined. You do see where they expect to see a significant decline. And then another thing that I've seen is how are our ADLs being affected? How is our weights? How our weights are applicable, and then level of care. And so when we're not addressing those things, they are really looking at, well, here, clearly there's nothing different in the ADLs. And one of the things that I'd like to tell my clients, even if you don't see that they went from needing assistance with 3 ADLs to needing assistance with 5 ADLs, still document that the patient needed some assistance or partial assistance or light assistance with 3 ADLs, but we have seen them decline to needed a full assist with 3 ADLs. So that is a different look at what the ADLs are looking, even though we're not adding one. So it's just looking at that patient, really focusing on your case conferences, your IDG meetings, and extracting that information, because your nurses, they know what's happening with this patient and they know there is decline. So you're going to pulling that out and making that into a really solid CTI is really going to help.
I feel like something that I'm seeing in the CTIs pretty regularly is that it's a silo, that there's no comparative data in there at all. So the physician is is doing their best, right? I'm not criticizing our physicians here at all, but they're taking the information from this benefit period, plugging it in that CTI based on a look back of maybe the last research visit, or however, however that most recent visit with the RN is structured.
Mhm.
But that's not really adequate to reflect the decline and really prove that prognosis is terminal and not custodial. And that's where I think I'm seeing some issues.
And we go back, and you make a really good point that our physicians are doing an excellent job, but what are they really used to doing? Is they're used to treating the patient and writing an order. And I think sometimes they view that CTI as the order, where they're saying, hey,
Yeah.
I'm writing this order. I certify that they're terminally ill. And that's how, you're just like, oh, okay. And they did their job. Because as you said, not calling CMS out either, but they have given us the regulations in the Medicare Chapter 9 manual that says that a physician certified.
I think you froze, Alicia. I don't know.
Am I back?
You're back.
Oh, good, good. Sorry, I don't know what happened there.
Okay. That's okay.
So, and we want to make sure that we explain to them, yes, you are writing an order, but we just need a little bit more detail. And it's that educating and just kind of walking them through that process, because they're used to a different way of documenting a disease process. Well, you have a cold or you have an infection. I'm going to order this for you because that's what you need.
Right. And I think having that crossover, it seems like you've got the field nurse documenting in that visit in real time with that patient, or afterwards at their house, right? It's not always real time, but pretty real time. And then they're capturing what they see. And then there's the physician who's reviewing the most recent face-to-face and the most recent maybe RN assessment, but there's kind of sometimes no bridge between that happening. And so, if you don't have a clinical manager or someone helping facilitate a bridge between the nurse documentation and the physician documentation, what I see is you have two totally different things going on in the chart. You have the nurse capturing this assessment that's accurate according to her and her nursing assessment. Then you've got the physician capturing the CTI according to the medical history, according to the medical assessment that he did, also correct, but they don't collaborate on why the patient is terminal, and they don't contribute to that proving that that's where this is going, right?
Exactly. Sometimes you'll look at it from, as you and I, we look and we're going through these audits and trying to put a response together. And we look at it and we're like, is this the same patient? And I've caught myself like retracting from the file and saying, okay, who was I looking at? Because it doesn't look like the nurse and the physician are talking about the same person.
Yeah.
And so that's a very good point, is we need to bridge that. Let's become a union, I think somebody put there.
Yes, I loved that. We got to be in unison. They got to match up. And anybody who's talked to me for 5 minutes knows that I'm kind of tough on EMRs, because clicking boxes does not equal compliance, and clicking boxes also does not reflect prognosis. So it's like, just because you check a box that says, yes, this patient is terminal, yes, this disease process is ongoing, yes, this is still their primary diagnosis, yes, this is their PPS, yes, this is their FAST, that's not enough to prove prognosis. And the auditors, maybe it's something about how our brains work, but when we're looking at those things, that doesn't tell me anything about their prognosis.
Yeah. What happened with this patient?
Right.
I have seen some softwares where they'll, in their IDG meeting, they're clicking, and so they put physician's narrative optional, nurses optional, everything is optional. But in this meeting, it is not optional. So did you speak about anything when you met about this patient? And how does that How is her nursing? How is her psychological? Was chaplain there? And you have like all of these little check marks, and then it's blank. And I'll go back and say, okay, what happened? Where's the documentation of this? Oh, there, you have it right in front of you. And I'm like, that doesn't tell me anything. Like, I don't know what happened with this patient at all.
I love that. I love that you brought that up because I have experienced the same thing. And when you're looking at the record, especially when it's a lot of box clicking, it really doesn't paint a picture at all of what's been going on with the patient. It really doesn't tell a story. I do find a lot of helpful information in the nurse's narrative that even when there is a box to click, it's not there. So, like, I'll go back through and read the nurse's narrative or a collaboration note or a coordination note or something like that that was put in, and it'll say something like, ordered a rolling walker due to patient's fall last week. And I'm like, wait a second. And I'll go all the way back to last week. Nothing,
Mhm.
literally nothing
Mhm.
there, right? There's no event form. There's no incident report. There's no assessment that we went to the house and assessed whether the patient was hurt from that fall. There's
Mhm.
no
Mhm.
call to the family to discuss safety interventions. There's no fall care plan. And really, like, for me, um, that's a big miss, not only on the
Mhm.
compliance side and from like a regulatory standpoint, a surveyor will pick up on that note in a
Like
heartbeat,
that.
right?
Mhm.
But also from the prognosis standpoint of like these things are getting worse. We're showing that that decline is going that direction, but we missed a huge opportunity. And I see that just crazy in these records that we are missing the opportunity to show there is a lot going on. And when you look at the record, like you're saying, from an auditor's standpoint who doesn't know
Mhm.
this patient at all, it looks like there's nothing happening here. They are a nursing home patient or a group home patient that is thriving under their current care plan.
Yes.
I mean,
Yes,
really,
exactly.
there's no
Exactly.
necessity, there's no need for an extra layer of care, and that kind of contributes to a whole separate area of the ADR
Mhm. Mhm.
is proving that
Exactly. Exactly.
necessity. But it's all kind of feeds into this same stream or this same river of missing it, like really missing it with our documentation.
I think another big miss is appetite and
Yeah.
eating. So if you have a patient and you say, "Did the patient eat today?" and they say yes, well, how much did they eat? So I've literally seen where there's a patient who did eat, but she eats one taco in the morning and one taco at lunch and then doesn't eat any more throughout the whole day. So then from a nursing perspective and as a group, decide what does that look like? How if you were to put that on a plate, she really is eating one meal, the whole day, and maybe not even that full meal. And that is a decline based on her eating, two full meals, maybe 3 or 4 months ago. But because the nurse didn't document that what the meal was or how it was being given to her, that was a missed opportunity. So it took a lot of digging and I kind of ran into it, but I'm like, wait a minute, a taco of what? And then I started asking, what was she eating? And how was she eating it? And did she finish the full? So at that point, we were able to determine that she's really eating 30% in what, if we calculate 100% eating for the whole day, she was eating 30% from 75% 3 months ago. That is a huge decline, and that's a missed opportunity as well. So what we have to ensure that we are proving at any given time is, one, that we have medical necessity, whether we're in home health or we're in hospice. We had the medical necessity, we had the need for either or. And then once they're there, of course, in hospice we have to prove decline, and then in home health we have to prove that we're getting them ready and getting them discharged, right? So make sure that that is what you guys are doing when you're preparing these responses.
One thing I know you mentioned just briefly earlier, but I think also kind of goes into this appetite. and Peter's comment here, he's talking about, do they require encouragement to focus on eating, staring at their plate? There's that mentation element. And one of the things you touched on really briefly is like that psychological, psychosocial aspect that, as nurses, I feel like, and maybe this is just a me issue, we don't capture super well. We're just not, we take that as sometimes as like, that's just how this patient is. That's her personality. She's just down. She's just critical. She just is unhappy, whatever. And we're not capturing that as like a symptom of a terminal prognosis is she doesn't want to eat, right? She doesn't, she's not excited about eating. She picks at her food. She says, I don't want this, she'll only eat ice cream. But some of those psychosocial, psychological impacts can really help, give some color and some detail around why she's not eating. It's, or like you said, appetite, like she says she knows she should eat, but she just doesn't feel hungry anymore, right? Like those type of details that really help give that backstory that we need.
We had a provider that we would ask her, has the patient eating? Oh yes, she eats every day. And then the husband heard the question, and she goes, does she tell you that it takes her 2.5 hours to finish a meal, and you have to sit with her and feed her most of the time, and remind her to swallow? And like, if that's a completely different story from the provider, but the provider was trying to say she eats because it was reflective of her job, right? And so she's trying to make sure that we know she's doing her job, but she wasn't giving the full picture. So exactly, we have to go in there and kind of dig a little bit more to see how long is she taking, how much is she eating, how like this woman would literally hold the food in her mouth, she was forgetting to swallow.
Yeah.
So all of those little cueing things should be documented.
Yeah. I don't see a lot of that in the records that I'm auditing. I don't see a lot of that level of detail.
Yes.
And again,
But I bet you they discussed it in the meeting. I really bet you they discussed it in the IDG meeting and they just didn't document it. And that is the problem. It's like, if you would just document exactly what you're seeing, or your conversations with the husbands and the caregivers and the wives, you would realize that, just document it, that ADR would just fly on through.
Yeah. I think that's really important. Documenting those conversations. That's one thing I've talked about from a leadership standpoint that I think can really help, that we don't think about. But as a director of operations, as an administrator, as a director of clinical services, when we are having those conversations, we can document that. We can document those conversations from a manager standpoint to say we're helping collaborate and manage the plan of care from a 10,000-foot view, right? Maybe we're not going to document something that didn't happen, where we're saying that we, assessed the patient, right, when we didn't. We're at the office, but we can say, I had a conversation with the spouse where he verbalized frustration about the length of time it took his wife to eat, and her, her symptoms of appetite loss, and her symptoms of no interest in pleasure or food, or these things. If we are the ones having that conversation, if they're calling the office to say, I want to talk to my nurse about this, or I want to visit from my nurse, we can document that and say, had a discussion with the case manager based on a call from the spouse today that voiced concern about her decline, and about, those are important to show that we are really coordinating the care more than just like, day-to-day custodial things.
I think my number one tip for ADR and how to really humanize who's looking at our data and how we need to present it is the story. We all want to understand the story. And if you're really explaining the story of this patient and their medical necessity and their medical decline of their terminal illness, you will not have a problem. We have to be able to present this story and it be able to make sense. And at the end of the day, we know we're all following the rules. We know we've all put in our time. And I've had clients that come in are in tears. If they only knew, she died a day later, and this
Mhm.
happened, and and then I'm like, okay, but even I'm struggling to figure out, to see where that much care went into her. And if I'm struggling and I'm on your side,
Yeah.
you know you can understand how somebody who is on the other side looking at things is going to feel. So let's write this story out correctly. And so now I'm interviewing nurses. Now I'm interviewing, tell me about this patient. And then I get the pushback, well, it's all there. And I'm like, I don't think it is.
Yeah,
I
it's
don't
not
think
all
it
there.
is. Mhm.
Yeah, I totally agree with this comment that was shared. I think over time, RN case managers become desensitized to the subtle declines. I totally agree with that. And I also think not just RN case managers, I think also aides, just
Mhm.
having been a CNA myself, right?
Yes.
You are so intimate with that patient that um, when and I think in any role, honestly, when you're in the weeds with
Yes.
somebody in that moment, you have tunnel vision. I'm in this moment, it's all I can see. And then somebody else above that moment, looking at lots of different moments, is like, but
Mhm.
wait a second, last week, did you have to totally transfer them into a chair? Last
Mhm.
week, they got up and took a shower. And this week, you said they could not physically get up and take a shower. You had to, bathe them in bed. That's
Mhm.
a huge decline, right? Um, but we don't always see that because we're there with them, like, oh, she didn't feel like it today. Well, why didn't she feel like it? Because she
Mhm.
physically couldn't stand up, because she was
Mhm.
hurting, she was tired. There's probably a good reason. How
And
much?
go ahead.
Sorry, go ahead.
No, I was just going to give another example. Even when you have a bedbound patient, and if they're able to help you assist when you roll them over, but then you go to the point where they're just not able to assist you, a lot of times that's not even documented. Like, like you said, last week she was able to put her right arm and help. And today she just wasn't even able to lift her arm. But the aide wouldn't catches it because she's having to do all the work, but doesn't see the relevance of that, and
Mm.
how that little minute thing is a significant decline in the patient's well-being.
Well, and I'm sorry to beat a dead horse here, but back to checking the boxes. If your aid care plan and your aid task assignment is them checking boxes, how are they supposed to
Mhm.
how are they supposed to reflect that information if they did recognize it? Okay,
Mhm.
assist the patient to reposition. Check. That
Yes.
does not reflect any decline anywhere. It's a
Mhm.
task, right?
It's a big
So
plus.
in an
Yes, I
effort
get it. Mhm.
to be compliant and in an effort to make things quick and easy, we have eliminated the opportunity completely to see the relevance here.
Mhm. Mhm. And that's why I think we're where we're at, where it's just such a big struggle for people to even go back, even from an owner's perspective, right? So when you're going back and you're saying, well, this documentation isn't enough, then the clinician is like, what do you mean it's not enough? Where am I supposed to document this? I did what the software told me to do.
Yeah.
Mm.
How much does what I was going to ask you was how much, in your opinion, does diagnosis have to do with prognosis? I see different diagnoses, and I know that some of these diagnoses that are unclear outside of the LCDs, are those flagging for ADRs? Are those contributing to being denied? What are your thoughts on that? Am
I think
curious.
that might be I think it's an easy ADR to, you know, I think it becomes like, oh, wait, I'm going to use congestive heart failure as an example. There's so many levels of that, and while someone can be on hospice with, if they are super declined and really suffering from this, but one of the things that I like to tell my clients is I have congestive heart failure. That means nothing. I'm not hospice appropriate at all. And so I think that when you see a diagnosis like that, then you begin to think like, well, this is going to be an easy ADR, to win, because did they really did they really need it, and did the hospice document that decline? You know, and that's important. So I do think that diagnosis sometimes does kind of lend itself to say, oh, this might be something we need to look at.
And that's where the auditors are digging into, okay, so does this support a terminal prognosis, or does this support a custodial prognosis? And then even further outside of the prognosis into medical necessity. If then I can't prove really clearly that this patient is terminal, then I also can't prove that there's the medical necessity of hospice being in the picture at all, right?
Yeah.
Or if they're a very high functioning patient, sometimes that's hard to prove without a black and white cancer diagnosis or something like that, because their their PPS might, excuse me, still be high.
Water break.
Yes, thank you. So allergies, y'all. It's wicked.
They're bad. That's
mute
this fuzziness. I'm not that old.
Okay, I think I've recovered. So those were just some of the things I wanted to talk about as we're looking at proving prognosis in these records. Is there anything else you feel like we need to touch on that maybe we haven't?
Well, thank you, Pastor.
I just gave it to you.
Excuse me. I think that if we focus on prognosis, documentation, and the follow-through, always close the loop. So if you have a fall and close the loop, remember that they're not going to just want to see that you documented that she fell. They're going to want to see what you did, how you prevented it, what teaching did you do, the whole thing, an incident report. So make sure you're always closing the loops on these opportunities, because now your ADR would have gotten denied because you didn't have an incident report. You didn't close that loop. And so an ADR can be denied for any reason, a signature, a date, a timestamp, for any reason. So make sure that you always go full circle. And I think somebody said here, paint the picture.
Yeah, for sure. We've talked a lot about different things that you can do to improve the documentation, which I think is really helpful. But one thing I think is we miss this when we're auditing a lot. As an auditor, we're looking for specific things, but in the agency, we've got people, I'm talking to agencies who have a full-time person doing QA, right?
Yes.
And so I am not criticizing that. That's a great thing to do. But I know I've heard a little bit of like shock and dismay. Like, we have so many levels of internal review of our charts. To get all these ADR denials is so frustrating and disappointing. And how are they getting us on this? We've got a full-time QA nurse, and I do have the heart to say it does not matter if they're not looking for the right information. I have no negative feedback for having a QA nurse. That's great that you have the budget for that and that's something they can do. But if they're not looking for the right things, they can be kicking back documentation to nurses 100 times and still not getting back the quality of documentation that they're looking for, because it's going to depend on the culture of your agency. It's going to depend on the approach to the education you're providing of what you need. A lot of the times QA is very task oriented, and again, back to the checky boxy, because this doesn't reflect the timestamp. This section isn't filled out completely. I'm sending this back because of the order doesn't have the frequency or the route or what, there's
Exactly.
very specific things that your QA nurse is looking for, and capturing the prognosis probably isn't one of them. I could be totally off here, and every agency.
No, you're 100% correct. You're 100% correct, because I used to be that QA nurse, right? I used to be that person, and I would kick it back based on something that I created off of the system, because my goal was to bill. Because that becomes the goal for that QA nurse. It's like, you haven't finished your note, you didn't, but when you have someone from the outside come in, look at your documentation and really tell you, listen, this is not the full story. This is not gonna work, but I know that we can make it work. Let's have a team conference. Let's go back and open up some notes and have them add that information that they had anyway. They just didn't document it. Let's go and really talk about this patient in the cover letters, in and putting everything together. It really does help. I mean, that's why I really encourage people to take the time to train on how to review an ADR, how to respond for an ADR. Take that time. It is worth it. That QA nurse that you have full time should be getting this training and
Yeah,
understand the full spectrum of what needs to be QA'd.
I agree. There's one more thing I wanted to bring up before we wrap up our time. Um, as far as discharge practices, so when we talk about prognosis, I wanted to bring this up. I don't want to let this slip by. I'm seeing out of a very genuine desire to do what's right and be compliant that when a hospice gets an ADR or a TPE or has a patient whose diagnosis or trajectory is a little less clear, I'm seeing a little bit of red flaggy discharge approaches here. And so I just wanted to have you kind of from your experience give some feedback on when do we do that discharge for prognosis and plateau, because I know that's always been super unclear, but in the lens of being audited is what I'm
Mhm.
specifically talking about. What is
Okay, so
your perspective here?
in looking at it through the ADR lens, I
Yes.
think that we need to really consider discharging a patient correctly, um, that their well-being would not be deterred, is when you have that stable, and it really should, if it's consistent through a couple of weeks, and if you are documenting patient is stable, patient has increased appetite, patient is was able to walk 5 feet, 6 feet, 10 feet without shortness of breath, whatever the opposite was before when you were documenting the decline. So when that starts shifting over to, you see where the patient has gotten improvement. Now I don't want to mislead anyone. When a patient is on hospice, they are going to improve because we're helping them, we're having that direct care. So you are going to see those times where the patient, you do see signs, and the family is going to see where they are improving a little bit. That doesn't mean that their terminal illness is not declining. That just means that their well-being in that moment, going from someone who was not in the medical field to having someone there almost every day tending to them and making sure that their pains are controlled and all of those things are happening, is going to cause improvement. So that's not what we're talking about, right? We're talking over a period of time where you see a complete shift. So then when you are in your meeting and you're saying this patient has stabilized, then you take the appropriate steps to, one, document that. And when you document that, let's go back to the other notes and put the dates. On this date, she went from eating, half 33% of her meal to eating 75% of her meal. And she has been consistent with that for the past, 21 days. And she's been consistent with that for, her medication, she's tolerating medication, pain levels are down. So then we show that comparative. The way you show a comparative to decline and to keep to certify terminal illness is the same comparative that you want to use to discharge. So those things should no longer be true.
Absolutely. I think I see a little bit of um, I don't want to say knee jerk, but like reactive decisions being made related to audits. Like, should I stop admitting? Should I start admitting a bunch more to get my percentages? Should I discharge every single patient on this ADR because could be denied? And I
Yeah.
So it's like I see a little bit of reactive management that really
Mhm.
doesn't have anything to do with the patient, right? It's really,
Exactly.
we're really not even looking at what the patient's needs are here. We're saying, I'm afraid of what could happen, which is totally understandable, right? Or I'm afraid that I'm not doing the right thing and I want to do the right thing. So, in response to now having these extra eyes on things, what should my response be to that? And then kind of making this widespread reaction to that
Mhm.
is a little bit that's kind of what I meant by a little red flaggy is
Mhm.
exactly is we really don't want to be doing things across the board that have nothing to do with our patient's plan of
Exactly.
care.
Because if you are focused on the patient's plan of care, you're going to be fine.
Yeah.
Like if you're focused on their well-being, you're going to be fine because we will take this to hearing. Like we will appeal, like, and we have the ability and the training to appeal all the way to hearing. So don't worry about getting denied. If you get denied once or twice, or then we're able to go to that for you and help you and assist you to resolve that. So don't discharge because you're scared. That's not what you should do.
Yeah.
You should maintain the patient's integrity and your business's integrity and servicing the patient. Let's take care of the patient. Let the nurses take care of the patient, and then you have people like Nina and myself that can help you take care of the ADRs. And
Yeah.
then you have a team. You could use your teams correctly.
And, from an internal standpoint, I think the most important thing I could say is start pressing pause. It's really hard to orchestrate 100% staff in services and do a deep dive for 3 hours on a chart. That's really not feasible for most agencies to stop operations every week to do a deep dive chart audit with all of your nurses to do this education on documentation that really needs to be done to get these charts to the level we're talking about.
Yes,
So when
exactly.
I give my advice on operational efficiency and compliance in documentation, I say just start pressing pause. Whoever's your strongest educator and maybe your clinical manager, have them start tag teaming some of these notes. If they're doing daily note reviews, if your QA nurse is doing a daily note review,
Mhm.
pick a few areas of focus and then start pressing pause when you see that. Ask your nurse to call you when she has a few minutes, or ask your nurse to stop by the office, or however
Mhm.
you can structure that best to do that, to show that note and say, I caught this here and I see this work that you're doing, but it's nowhere else. And I really
Mhm.
want to reflect that you are really providing this excellent care for this patient. And so
Exactly.
taking those moments to capture that might be more effective for you than trying to do an 8-hour documentation in service or hiring someone external to do that, right? Like I love doing that. Don't get me wrong. I love doing documentation education, but it's not always feasible to do that, right? To pull everybody out of the field for that.
So, how long did it take anyone to learn anything? For all the professionals on today, myself, you, how long did it take us to really learn something? So, if you're starting with with a topic that your clinician, your field clinician, that is an expert, excellent field clinician, and you're taking her out of her environment and putting her in a classroom and not giving her all the resources, because what we see that some clients do is they invent policies for themselves that have nothing to do with the regulation. So now you're teaching
Don't
them,
get me
and you're
started,
doing,
Alicia. We don't have time.
and so now you're teaching them on your policy. When you should be teaching them on what the rule is and what that focus is.
Exactly.
Don't and while I appreciate everyone should have their policies, their procedures, the way that they want their business run, but when we're dealing in the ADR world, because it is a completely different world, you want to be straight to the point. What do you want to learn, and how are you going to learn it? And you want to have that person in your office that is that subject matter expert. And that's I think that's the clue, is that you have to understand that ADRs are not going away. They're going to be here for as long as we have these businesses open. And so you want to have a subject matter expert in your company, in lieu of having a consultant, on retainer to help you with this. And you want to ensure that you understand that an ADR isn't about that 30-day time frame. An ADR is about everything that happened with that patient throughout the life. While you might not submit all of that paperwork,
Yeah.
it does deal with the life of the patient with you, not just that 30 days.
Yeah. And understanding what they're looking for is so important.
Mm-hmm.
Well, thank
Yes.
you so much. This, I love having these conversations with you, and even better that this one is shared with other people and not just between you and me. Um,
Yes, I know. We could go on for hours.
Exactly. If you don't have an internal expert and you need one, our ADR Academy in Nashville in June 4th to 6th, is the perfect opportunity to do this, to get that expert internally. We will train your internal expert on ADR response so that when it does happen, they can take that information back to your agency, train the clinicians on how to prevent this from happening in the future, but also be able to respond to that ADR in a way that is going to not only save your revenue, but also reflect the quality of care you're delivering and your compliance with CMS regulations. And so, in celebration of our 2,000 ADRs completed, we are sharing a very special and very temporary coupon code, 2,000 ADRs, ADRS. And you can see that ADR Academy QR code up there in the corner. If you're interested in more information on that training, you're welcome. You guys are welcome. Thank you for joining, and thank you for being so interactive. If you want more information, I shared the link with the coupon code for 2,000 ADRs. That'll give you $500 off of any option. So the first day, that in-depth ADR training. The second day, day 1 and 2, which is the certification review, and day 1 review is day 2. And then that certification and ADR manual if you get the whole bundle. So there's 3 options of how to participate. You can just come for day 1, get the ADR response education. You can come for both days and do the certification review and the certification test. Well, and you can get the whole bundle, which includes that ADR manual and some extra bonuses in there. So you can see what those options are at that QR code right there. And you can use the code 2000 ADRS to get $500 off of any option. So we'd love to see you in Nashville in June. We're super, super excited for the opportunity to train your agency experts on how to respond to ADRs so that you can feel very confident that those are going to be approved.
Thank you guys so much. Appreciate you guys
Have a
attending
great
today.
week. Any questions, let us know. Shoot us a message. We're happy to help.